Dr. Vishal Mohan. Vishal has completed his MD from Amla Institute of Medical Science of Kerala. Now is a leading consultant of KM Institute, again a very famous hospital in Kerala. Thank you, Vishal, for joining today. And today the topic of discussion is how to manage an anticholinergic toxicity, and also a few more details about the iron toxicity, which is a very important theory exam for the exam going students. And over to Dr. Vishal.
Hi, thank you for the warm welcome, Dr. Srijit. Am I audible?
Yes, you are audible. Yes.
All right. Thank you so much for the warm welcome. So today's topic is actually like what Dr. Srijit mentioned. It's about anticholinergic toxicity and iron toxicity. So especially these two drugs. So it's very important for us in an exam point of view and also in a clinical point of view. The anticholinergics, what we should understand is the anticholinergic drugs, it affects in a more in synaptic level. Okay, and the iron toxicity affects a more cellular level. Okay, so we'll be covering much more into these topics as we go forward. To make it more interesting, I would like to start this discussion with a few questions. This is just to it's for you guys just to know what are the information that you know about the toxicity or not. We don't have to comment on any of these topics or questions. Just keep in mind which is the answers that you have in mind. So as the discussion progresses, you will have an idea of how what is happening, your answer is right or in modification in the end. We'll be covering the answers towards the end of the session. All right. So this is the first question. What specific clinical finding corresponds to a toxic, uh, sorry, yeah. So what specific clinical findings corresponds to the classic toxic drome mnemonic phase, blind as a bat? Is it a loss of accommodation and mydriasis? Is it toxic optic neuritis, a bilateral retinal detachment, or a central cortical blindness? Just take a few seconds to have an answer in your mind. That's it. Okay. Next question. An adult patient presents with an intentional diphenhydramine overdose and an altered mental status. What specific ECG abnormalities dictate the continuous cardiac monitoring? Is it a PR interval prolongation and delta waves, a QRS interval widening and a QT prolongation, an ST segment elevation and a T inversion, or a peak T waves and an absent P waves? Which do you think is the right answer? All right, shall we move forward? A patient exhibits severe central delirium, picking at imaginary objects and an incoherent speech following a gemcitabine, it's a datura ingestion. What is the specific antidote for this profound central antimuscarinic toxicity? IV naloxone, IV flumazenil, IV physostigmine, or an IV sodium bicarbonate? Okay. The next question. Administration of physostigmine is being considered for agitated anticholinergic patient to avoid physical restraint. What is the absolute contraindication to the use of physostigmine? Is it sinus tachycardia more than 140 beats per minute, wide QRS interval with a history of seizure, severe painful dry mucous membrane, or a sustained hypothermia more than 39 degrees Celsius? Moving forward, a toddler accidentally ingests a handful of maternal prenatal vitamins containing ferrous sulfate. What ingested dose of elemental iron strongly correlates with severe systemic toxicity? Less than 20 mg per kg, 20 to 40, 40 to 60, or more than 60 mg per kg? Okay. In acute severe iron toxicity, a patient rapidly develops a profound high anion gap metabolic acidosis with an elevated lactate levels. What is the primary cellular mechanism driving this metabolic derangement? A disruption of mitochondrial electron transport chain, inhibition of renal carbonic anhydrase, a direct necrosis of pancreatic beta cells, uncoupling of oxidative phosphorylation by salicylate. We are moving forward. A patient with an intentional IL overdose stops vomiting 10 hours post-ingestion. Their abdominal pain subsides. Patient becomes clinically improved. What is this phase? And why is it dangerous? Phase 1 is GI phase, immediately precedes by coma. Phase 2 is latent phase. Third is systemic phase. And the fourth phase is hepatic phase. Okay. A patient provides an unclear history regarding the type of medical ingestion. What widely available diagnostic imaging modality is frequently useful for confirming the ingestion of significant amount of iron pills? Is it an NCCT, an ultrasound, abdominal X-ray, or an MRI? Moving on. In cases of massive iron ingestion, where decontamination is strictly indicated and numerous intact pills are visualized on imaging, what is the preferred method of GI decontamination? Activated charcoal, ipecac syrup, induced emesis, a gastric lavage, or a whole bowel irrigation. The next question. A critically ill iron poison patient receives IV deferoxamine chelation therapy. What clinical urine color change indicates the successful formation and renal excretion of chelated complex? Is it a fluorescent yellow-green, a windrose pattern, cola-colored or dark brown, or a bright blue-green color? All right, so this is the end of the questions. So keep the answer to your mind. We'll see at the end of the session if the answers are right or any modification during the process. Okay. So like usually, we'll start with the case presentation. Okay. So we have a 24-year-old male patient brought in by his mother, who is brought in because the patient is agitated, mumbling incoherently. He's kind of delirious. Okay, so we give a history of the patient is having a fever and cold for the past few days. So he got some medications over the counter. He's been having this for the past few days, and then suddenly at around 3 a.m., the mother found him agitated and delirious, and then they brought the patient here. As part of the primary assessment, we'll start with an ABCD assessment. All right. So there we was waiting for the patient, no issues, breathing was fine. We go into circulation part. Here, the heart rate of the patient is around 135 beats per minute and a BP of 145 by 190. Okay. And we also found that it is a dry mucous membrane around the lips. Okay. Starting with the patient, the two large IV cannulas and everything is placed. Okay, going into disabilities, GC is around 1415 by 15, GRBS of around 140, patient stable. And then we go into the exposure. Here, we found that around 38.9 degrees Celsius as temperature. The patient is hypothermic. So as part of the initial, that patient was having fever, rhinitis, and then he's tachycardic, hypothermia. So naturally, we'll think about some kind of a, febrile delirium or sepsis for this patient, we'll start the patient of an antipyretics, we'll start IV fluids for the patient, and we'll start, after the primary assessment, we'll take the initial blood samples, we'll be taking ABGs, counts, everything. And also, since the patient is delirious, we'll try to rule out what are the other causes of delirium for this patient naturally. We'll go forward with normal blood samples, CT, brain can be indicated for this patient. We can take all this patient. But while during the examination that we found that the patient's, like I mentioned, dry mucous membrane for this patient, okay? When examining the delirium, we checked the pupils as well for the patient and we found that it's around 8 millimeters and the pupils are sluggish, okay? And delirious patient. So suddenly we tried inquiring with the mother again to know if there are any significant histories. And the mother suggests that, so the 2 days back over the counter, they took medications and he's been having this medication for frequent use, okay? And the tablet packets were empty at home. So possibly he might have had some kind of antihistamines or something from the local pharmacy. He's had it probably because of that. So in case of, so it's a basic toxic drome symptoms. Okay, hypertension, tachycardia, hypothermia, pupils are mydriatic, dry skin, etc. So that's when we understand that we are not dealing with any febrile patient. We are dealing with a toxic patient, toxic drome patient. All right. So in this patient, what we should know is what are the drugs that can actually cause these kind of symptoms, especially in an anticholinergic toxicity. Okay, there are a lot of medications that actually causes antimuscarinic anticholinergic effects, but the ones that on a day-to-day basis are the ones that, like how I described, is an antihistamine medication, diphenhydramine, chlorpheniramine, etc. Patients on antipsychotics or antidepressants can also have antimuscarinic activities. Patients on antispasmodics and mydriatic like dicyclomine, atropine, cyclopentolate can also have antimuscarinic activities. Okay, we plant a natural alkaloid like datura, atropa belladonna, and amanita muscarina can also have antimuscarinic symptoms. So in these kind of patients presenting with these kind of symptoms, we need to know anticholinergics. What is actually an anticholinergic medication? Okay, what are the pathophysiology of it? So basically what happens in an anticholinergic drug intake, okay? For example, in this patient, probably it can be a diphenhydramine injection, okay? So what we need to know is they completely inhibit the muscarinic receptors and the nicotinic receptors are actually completely unaffected, okay? So all these muscarinic receptors like M1, which are usually present in the autonomic ganglia, brain, and salivary glands, causes reduced activity and reduced secretions. And the M2 receptors present in the heart reduces the SA node rate and the AV conduction. In the M3 receptors present in smooth muscle, iris, exocrine gland, okay, causing bronchospasm, meiosis, and salivation. The M4 and M5 is present in the central nervous system. So these are the muscarinic symptoms and its action, okay. So in an anticholinergic drugs, they inhibit the muscarinic receptors, okay, causing a parasympathetic nervous system, okay. So what actually happens? So these medications, they competitive inhibition of the muscarinic receptors in the postganglionic parasympathetic nerve endings. So what happens is they go and bind towards the muscarinic receptors where the acetylcholine, they are not able to bind to the muscarinic receptors. Okay, so the acetylcholine activity completely reduces, causing an unopposed sympathetic tone and a parasympathetic failure. And the acetylcholine will be there in the system, which will be further broken down by the acetylcholinesterase. And the level of acetylcholine will also be less for this patient. Okay. Another thing, along with the, apart from the muscarinic receptors, okay, which causing the classic toxic drome in this patient, diphenhydramine can actually affect the sodium channel blockage in the cardiac membrane. Okay, it can actually cause a myocardial conduction delay, causing wide complex tachycardia and activity prolongation. This is mainly seen in a diphenhydramine overdose. So where the muscarinic receptors and the cardiac sodium channels are actually blocked. Okay. So the symptoms that we can actually see are at two different levels, central and a peripheral. We know about these symptoms. So the peripheral ones, we'll discuss about the peripheral symptoms. In the eye, it can causes mydriasis, causes tachycardia, bronchodilation, causes ileus, urinary retention, and reduces sweat. And in case of a central manifestation, it usually starts with impaired memory, goes into confusion, agitation, delirium, hallucination, seizure, and coma. This goes into progressive nature. So patients can present central and peripheral symptoms. Okay. We'll discuss about the peripheral signs. We know this mnemonic: dry as a bone, red as a beet, hot as a hair, uh, blind as a bat, etc. So we'll discuss about these features. This is a mnemonic that we have actually known from before itself. Okay. So in these patients, what are the symptoms? Dry as a bone. So because of the salivary gland blockade, the mucous membrane becomes completely dry, and there is absence of sweat in this patient, and the entire mucous membranes are dry. Okay. Next thing, hot as a hair. So what happens here? Patient is hypothermic. The hypothermia is because of two reasons. One is because of, like we discussed, reduced sweating. So because of reduced sweating, the patient is not, the evaporative cooling is not happening. So in that way, hypothermia happens. The second one is the patient is agitation. The agitation induced hypothermia can also happen. So both of the features causes an excess hypothermia in this patient. Okay. Next is the red as a beet. So in these patients, they are not able to do an evaporative cooling. Okay, they are not able to dissipate the excess heat. So in these patients, it causes cutaneous vasodilation, causing a red color. Okay, that is called a red as a beet. The next one, blind as a bat. So because of extreme pupillary dilatation and loss of accommodation, this is basically because of the paralysis of ciliary muscles and the iris sphincter. We know the pupil becomes completely mydriatic. Okay, and he also completes a blurring of vision. The next one is because of reduced bowel motility leading to ileus. Okay, and a reduced detrusor muscle activity causes acute urinary retention. That is what is called stuffed as a pipe. Okay, so we discussed about dry as a bone, red as a beet, hot as a hair, blind as a bat, and stuffed as a pipe. And the next one is mad as a hater. So this is the central symptoms. So this starts with neurological toxicity, like starts with tremor, confusion, agitation, mumbling delirium, hallucination, seizure, myoclonus, and coma. So here one of the important clinical features that we need to notice is it's called Lilliputian hallucination, where the patient hallucinates small objects and he tries to pick them up. Okay, this is an important feature that we see here. Along with that, patient will be restless, mumbling speech, incoherent speech, etc. Along with these symptoms, the patient also shows ECG changes in the body, like how we discussed before, especially in diphenhydramine or a TCA. Patient will have sodium channel blockage, especially in the cardiac membrane, which causes prolonged QRS more than 120 milliseconds, QT prolongation, sinus tachycardia. Okay, this is not a muscarinic active effect. This is because of a sodium channel blockade. Okay, so in every patient who presents with a toxicity, we need to make sure that we get an ECG evaluated even before we start deciding on an antidote. Okay, so ECG is very important in these patients. In these patients presenting with classic toxicromes, we need to know, how to identify or differentiate between similar toxicromes. For example, in patients with an anticholinergic and a sympathomimetic. Okay, in these patients, how do you differentiate? Most of the features are actually kind of similar. The patient will be tachycardic, hypertensive, hypothermia, and mydriatic. These features are actually kind of similar. What differentiates between these patients? Main feature is because of the anticholinergic toxicity, the patient will have dry mucous membrane. Whereas in a sympathomimetic, the patient is actually excessively diaphoretic. This is a main feature. Along with that, in anticholinergic, there will be ileus and urinary retention. But in case of sympathomimetic, it will be normal or an increased bowel sounds. Okay, patient is agitated, hyper alert in case of a sympathomimetic. But in the anticholinergic, we'll be mumbling, like how we said, Lilliputian hallucination, mumbling speech, etc. So this is how you exactly differentiate between an anticholinergic and a sympathomimetic. The main feature is the skin. Dry skin in case of anticholinergics and a diaphoretic in case of a sympathomimetic. All right. Another important thing is how to differentiate. So basically, anticholinergics, it's because of drug toxicity, right? So we need to differentiate between the different drug toxicities. It can be an anticholinergic and a serotonin syndrome or a neuroleptic malignant syndrome. How do you differentiate between these common syndromes? Okay, in case of anticholinergics, we have discussed the tone is normal, reflex is normal, patient just has a mydriasis, dry mucous membrane, ileus, mumbling sound, hallucination, and reduced bowel sounds. Okay, when we go into serotonin syndrome, the important features is hypertonia. Hypertonia, hyperreflexia, and clonus. This differentiates this patient having a serotonin syndrome. When we go into neuroleptic malignant syndrome, the main important feature is the lead pipe rigidity. Okay, bradyreflexia. The pupils are actually normal. Severely hypothermic patient, diaphoretic patient. Okay, and there will be a recent history of antipsychotic use also in this patient. This is how you differentiate between an anticholinergic, serotonin syndrome, and a neuroleptic syndrome. Main features we need to know: serotonin will have hyperreflexia, clonus, hypertonia. With the mydriatic pupils, neurologic malignant syndrome will have lead pipe rigidity, bradyreflexia, normal pupils, excessive sweating, and hypothermia. Anticholinergics with the tone will be normal, reflex will be normal, pupils are extremely mydriatic with dry mucous membrane and delirium. All right. How do you manage a patient with anticholinergic toxicity? So, two things that we need to know: how do you stabilize the patient, how do you decontaminate the patient, and how do you treat the patient? Three things. So, how do you stabilize this patient? The patient may be presenting with an agitation or a patient with actives. Lorazepam, diazepam 20, we can be giving an IV dose. Okay, we can give for the patient. Along with that, to stabilize because of excessive hypothermia, we can actually give rapid cooling measures. Okay, if the patient has an ECG changes or we suspect a sodium channel blockade, we actually give because of the wide complex tachycardia, QT prolongation, etc. We give a sodium bicarbonate, 1 to 2 milliequivalents per kilogram for the patient to stabilize the patient. Okay. And the next is how do you decontaminate this patient? In patients with anticholinergic toxicity, gastric lavage is completely, they have no role and is contraindicated. We can give an activated charcoal for this patient only if the patient presents within an hour. Okay. But what we need to remember is in case of an anticholinergic toxicity, these patients will have reduced GI mortality. So this remains in the system for longer. Okay, if the patient have a seizure of the patient is with an altered sensorium, there is a high risk for aspiration in this patient. So even this activated charcoal we need to be very wary when we are giving this for a patient. Okay, and HT is completely ineffective in these patients. The next is how do you treat these patients? What is the right antidote for these patients? Okay, it is actually phytostigmine. Is a reversible acetylcholinesterase. So what happens is phytostigmine inhibits the acetylcholinesterase enzyme. So what happens is usually the muscarinic receptors, it's usually because of the anticholinergic goes and binds to muscarinic receptors. And because of that, acetylcholine levels are actually kind of high. So the more number of acetylcholines are actually degraded by the acetylcholinesterase. So what the phytostigmine acetylcholine will be there in the system. So they will be competitively, they will try to block the toxic agent in the muscarinic receptors. Okay. So this phytostigmine is actually a tertiary amine. Okay. It crosses the blood-brain barrier and it reverses the central delirium as well. So this is a reversible acetylcholinesterase enzyme. Okay. We need even before giving an antidote, we need to know the indication and contraindication of medication. Okay, where is it indicated? Muscarinic toxicity, the patient is delirious, agitated, etc. Central symptoms patient is showing. So we give a phytostigmine. Okay, where do you contraindicate phytostigmine for patients? The first one is a wide QRS complex. Patient might we have taken a TCA overdose as well for the patient. We need to get an ECG done. Okay, patient with bradycardia or an AV block. Patient with narrow angle glaucoma. Patients who's already had a history of seizure or presenting with active seizures. Okay, in these patients, a Pfizer statement is actually contraindicated and indicated in a patient with antimuscarinic toxicity with the central symptoms. Okay, the normal dose is 1 to 2 milligram slow IV push over 5 minutes, and the dose can be titrated. Pediatric dose is actually 0.02 mg per kg IV over 5 minutes. So what we need to know is the onset of Pfizer statement is rapid. It takes place between 5 to 10 minutes. Likewise, even the half-life is also short for this for a Phytostigmine, usually around 10 to 15 minutes half-life. So what we need to know is the once the Phytostigmine effect goes down, again the patient might show an anti-muscarinic symptoms. So a repeated Phytostigmine doses might be required for the patient because of its short half-life. This is something that we need to keep in mind. Okay. So, but how do you dispose this patient is something very important in our ED. Okay. If a patient presents to an ED with mild toxicity, normal mental status, normal vital signs, normal sensorium, everything, we observe the patient for around 4 to 6 hours. Okay. Till he's completely resolved of every symptoms, and then we discharge the patient. If the patient presents with large quantity of ingestion, prolonged delayed emptying, any large amount of plant heat or overdose, etc., we admit the patient and we observe for around 24 hours. Okay, due to risk of recurrent toxicity. Even if the initial Phytostigmine dose has been given for the patient can go into recurrent toxicity. Okay, if the patient presents with an agitation, delirium, severe hypothermia, wide complex tachycardia, seizure, central symptoms. In these patients, we actually start the patient on continuous cardiac monitoring, might need airway stabilization, might need antidote Phytostigmine. These patients might also need a continuous, like how we said, the onset is rapid, but also the half-life is also less. In these patients, we'll have to admit the patient in ICUs and then re-administer Phytostigmine also might be important. So this is how we dispose of the patient. We need to admit the patient or we need to uh, discharge the patient. Okay, so this is basically what is actually being covered for the anticholinergics. Okay, next we'll move on to the next patient, next case scenario. This is basically iron toxicity. Okay, so what we need to know about, we'll start with the case scenario and then we'll move into the details of iron toxicity. Okay, for example, in our ED, we get a 22-year-old female who is in her gestation age for around 20 weeks pregnant, around 60 kgs, brought in by her boyfriend to the emergency department. Okay, with the complaints of because of many reasons. Okay, so we should know possibly this might be a case of DS 15 to 20 minutes. So we'll start the patient on ABCD protocol itself. Airway, patent, breathing wise, the patient is fine, circulation is okay, disability is all right, exposure is all right for the patient. Then we will actually move on to the two things. First thing is what we need to know is it's just 15 to 20 minutes down the lane. Okay. So what should you do? It's because when it's usually within an hour's time, we actually decide to do a lavage for the patient because within an hour. So it's just a 15 to 20 minutes. So we'll decide to lavage the patient and we'll send for initial bloods as well. An ABC blood count, etc., can be given for the patient. Okay, and for example, this is just a 0.14. Okay, and a bicarb of 19, a base excess of -10 for this patient. So that means the patient is in severe metabolic acidosis. Okay, and in this patient we decide to lavage the patient. Okay, and during this lavage, what we see, what we noticed is the patient vomited this twice, and along with the lavage, we get these pill extracts. Okay, so with that, we understood that a lot of pills have been ingested. Okay, a lot of pills can be cleared. They give history that the patient had around 20 to 30 tablets were present at home, so they are not sure the number of tablets. Once after the initial intervention, we'll repeat the bloods, etc. Since the patient is relatively stable, GC is actually fine, ABCD is where the patient is normal. We'll repeat the ABGs and the patient will automatically go we understood that the pH is becoming normal, bicarb is increased, base excess has come down for this patient. Okay, and we also found evidence of the pills in the lab batch itself. In these patients, what is actually the most important thing in the initial step? Initial step is to identify how much is the iron elemental iron toxicity in this toxic dose in this patient. Okay, with that we'll have to grade the patient as mild, moderate, or severe. So how do you do it? So each tablet, it can around 60 to 100 milligrams of elemental iron, okay, into 20 tablets. So we get around 2000 mg or 2 grams. This 2 grams will be divided into the weight of the patient, that is around 60 kgs, and we get how much is mg per kg. For this patient, we have actually found it's around 33.3 milligram per kilogram has been ingested as the elemental iron dose. Okay, with this, we'll see if the patient falls into mild toxicity, moderate, or severe. Okay. In case of mild, if it's less than 20 mg per kg, it's a mild toxicity. The patient will present with mild GI symptoms, lower risk of systemic features. Okay. If it's 20 to 60 mg per kg, it's a moderate toxicity. There will be significant GI effects or moderate to severe systemic toxicity for this patient. If it's more than 60 mg per kg, it's a severe toxicity, severe systemic features and increased morbidity in these patients. Our patient falls into moderate toxicity of 33.3. Okay. We should know what is the normal elemental iron, which are the elemental iron, which are the normal iron tablets, the composition that been used, and each of the elemental iron percentage in each composition. If there is ferrous glucuronate, ferrous sulfate, and ferrous fumarate of around in glucuronate will be around 10 to 12 percentage. Sulfate will have 20 percentage, and fumarate will have 33. So usually we can, I mean, if you want to memorize this, it's like we can say GSF and 30. That is something I try to remember with that. So around 10%, 20%, and 30% of elemental iron per tablet. Okay. But even before all this, what we need to know about iron. Okay. What happens in an iron in its ingestion? So which gets reduced by an ferroreductase into ferrous state, and it reaches the GIT. Okay, in the GIT, it goes back from ferrous to ferric, Fe3 plus, which gets binds to transferrin, and it's usually lean and liver. Okay, ferrous to ferric to ferrous, then again comes back to a ferric in GIT and binds to transferrin. Okay, usually iron binds to transferrin, ferritin, and to a hemoglobin, myoglobin, cytochromes, etc. Okay, the main pathophysiology behind the effect of iron in the body. There are a couple of things that we need to know. One is the gastric irritation. The second one is oxidative stress, hepatotoxicity, coagulopathy, and a myocardial depression. So these five things are the normal pathophysiology: gastric irritation or corrosive effect, oxidative stress, third one is hepatotoxicity, coagulopathy, and a myocardial depression. We'll start with the normal. The first thing is the corrosive effect in the GI tract. So what usually happens is normal physiology, the iron is the ferritin binds to transferrin, goes through the mucous membrane, goes to the bloodstream, and goes to a normal circulation. Okay, in an overdose stage, what happens in this patient? Okay, because of an excessive iron, it causes corrosive injury in the mucosa. So once there is a corrosive injuries, the entire mucosa is deranged, and the iron rapidly it goes into the system. Okay, the free iron as a causing caustic irritation, corrosive injury, it induces hemorrhagic necrosis, ulcerations, and goes into the gastrointestinal mucosal barriers and into the bloodstream. So after it reaches the bloodstream, it goes into the systemic circulation and causes systemic features. Okay, in an overdose stage because of excessive iron. And the next one is oxidative stress. Okay, in case of oxidative stress, what happens? The free unbound iron is present. Okay, what happens is they are potent catalyst for production of oxidative free radicals. Okay, usually present near the mitochondrial membranes. Okay, it causes uncoupling of oxidative phosphorylation. Okay, one because of oxidative phosphorylation uncoupling, it goes into anaerobic metabolism. Anaerobic metabolism causing excessive metabolic acidosis and lactate elevation. Okay, so we discussed about gastric irritation and corrosive effect and the oxidative stress. It can also cause hepatotoxicity because of increased iron dose. Okay, and the next thing is important thing is coagulopathy for the patient. Why coagulopathy? Is because iron causes reduced thrombin formation, causing coagulopathy. Iron causes reduced thrombin formation, it causes coagulopathy in the patient. And the next thing is myocardial depression, is basically because of iron deposition in the myocardium. Okay, one of the main important features that we need to know is the stages of iron toxicity. This is very important for our exam point and also for on a clinical level. Okay, so there are actually 5 stages. Okay, the first stage is a GI toxicity. Okay, and second one is latent phase. Third phase is systemic phase. Fourth one is hepatic phase, and the fifth one is a delayed sequelae or an obstructive phase. Okay, the first one is the GI phase. What happens? It's because of direct acting on the GI mucosa, which causes abdominal pain, vomiting, and diarrhea. So this vomiting in this patient, it can actually resolve or it can go into systemic toxicity. Okay, so this GI phase directly affecting the mucous membrane and causing abdominal pain, vomiting, and probably diarrhea, hematemesis, etc. This usually happens at around 6 hours. 0 to 6 hours is a GI phase. Okay. After 6 hours, the patient goes into a latent phase. This latent phase is very important because most of the symptoms resolves this patient. Okay. All the symptoms vomiting, all the GI symptoms actually reduces. Patient is becoming all right. So this is actually a tricky phase for a patient with iron toxicity. Most people will feel like the patient is normal, is getting better, but it's wrong. It actually doesn't happen that way because the patient is actually might be going into severe poisoning. But this is a latent phase, and the patient is just relatively stable at this moment. Okay, this usually happens around 6 to 24 phase. So 6 to 24 hours. So the first 6 hours is a GI phase. 6 to 24, the patient goes into a latent phase whereby the patient becomes relatively stable. Once 24 hours is over, the patient goes into a systemic toxicity. Okay. So in systemic toxicity, the patient will be having some kind of cell damage, systemic features. The patient can show a cardiovascular symptoms. The patient can go into cardiovascular collapse. Patient can go into a shock. Patient can present with severe metabolic acidosis. Patient can have a coagulopathy. We discussed about coagulopathy. What happens because of the iron? It inhibits the thrombin formation, and patient goes into coagulopathy. And patient also can have neurological symptoms, like patient can having lethargy, seizures, or coma. So this systemic toxicity usually begins within 12 to 24 hours. Okay. So what we need to know about this iron-induced coagulopathy? It's basically two different phases or two different reasons why this iron-induced coagulopathy happens. First one is actually can be because of the increase in iron. Increase in iron causes reduced thrombin formation, like we discussed, causing initial coagulopathy. This phase is actually reversible with chelation therapy. Okay, but in a later stage, the liver can be affected because of excessive iron, because of hepatotoxicity, and patient can go into coagulopathy. In that phase, it is not reversible, and chelation will not help the patient. This is something that we need to remember. Why the and why a coagulopathy happens for the patient? Is it because of the initial phase, or is it because of the hepatic phase? And the next phase is actually the hepatic phase. Okay, in this hepatic phase, what happens with this patient? So usually what happens excessive absorption of iron through the portal system, a resorption of these iron by the reticuloendothelium. Okay, this can cause a liver failure, fulminant hepatic failure, STOT, STP rise, usually around 2 to 5 days in patients. Okay, around 2 to 5 days, and then the next phase is a delayed sequelae after 3 or 4 or 5 weeks. In the patient, it's mainly because of the corrosive injury. The patient automatically heal. There can actually patient can develop a pyloric scarring or even the gastric outlet obstruction in this patient. So the 5 phases we have learned. We start with the GI phase, we go into latent phase, systemic phase, and then we go into hepatic phase, and a delayed sequelae or an obstructive phase. Okay. And in case of in these patients, what lab investigations that we need to send? In our patient presenting the ED, we'll send all the routine investigations, a normal CBC, LFTs, RFTs. We send for coagulation profile for this patient and the serum iron. So what happens? Serum iron in this patient. Usually we send for a serum iron concentration, usually obtained after 4 to 6 hours of ingestion. This is the time where there's peak levels of iron in the body. Okay, so 4 to 6 hours after ingestion of the patient being sent for a serum iron. Okay, and once we get the iron dosage, we divide into minimal, moderate, or severe toxicity. Less than 350 micrograms per deciliter, 350 to 500 is moderate, and more than 500 is severe toxicity. Okay, in these patients, we cannot depend on total iron binding capacity for the patient at all. Okay, because it's inaccurate. We depend on mainly on the serum iron levels. Okay, patient will also get the ABG done to know if there's any anion gap, metabolic acidosis, any lactate elevations for the patient, etc. As part of our after the primary evaluation, we need to know if the iron pills have been ingested or yes or no. So this is an investigation that we are actually doing, an X-ray abdomen, right? Okay, in this we can actually find evidence of iron in the system. Basically, more ingestion usually happens for ferrous sulfate, and so we can actually it's a radio pick, and then we can actually get into the X-ray. Okay, chewable or a liquid preparations and the non-ionic compounds may not appear for the patients, but solid preparations, pills, etc., we can actually get an X-ray abdomen. This confirms our diagnosis of iron ingestion. Next thing is decontamination of this patient. So in these patients with iron toxicity, if it's between 1 hour, we can actually think of giving a gastric lavage for the patient. Okay, but if it's post 1 hour or the time is unknown for the patient, what we do is we don't give activated charcoal at all because the activated charcoal does not bind to the elemental iron. Okay, okay. The wash gastric lavage can be given only if it's within 1 hour. In our patient, the patient presents within around 15 to 30 minutes of ingestion, so we give a gastric lavage. Okay, and an X-ray abdomen can be taken, pill can be found evidence. We contaminate with the whole bowel irrigation, 900 ml per hour for children. In case of whole bowel irrigation in a with PEG. Give desferoxamine. This desferoxamine binds to the free iron in the circulation. So what is the name? What is to look for a wind rose color? Am I audible right now? I think I lost the connection for a second. I'm sorry.
Yes, you are audible. Yes.
Yeah, I can continue, right?
Yes, you
Okay.
can please continue.
Okay, thank you. So, like we're discussing, defroxamine is the IV chelating agent. So, it binds to the free iron in this circulation and it forms the ferroxamine, which is water soluble pattern. So, when we get this Windrose colored pattern, we understood that this defroxamine is acting and this chelation is happening. Okay, a normal dose is usually is around 15 mg per kilogram per hour. Okay, for up to around 24 hours, a 6-gram dose can be given, or a 360 mg per kg in around 24 hours can be given. Okay, in these patients, how will we identify when to stop this chelation? is mainly when this Windrose color pattern, it reduces. That means almost all the free iron has actually been reduced. That's the first thing. Or else if the patient is showing signs of clinical improvement. Clinical improvement, and also the patient is showing any Windrose color pattern reduction, we can actually stop therapy. Or else if the patient is showing any kind of side effect. The main side effect for a chelation with desferoxamine is a patient going into hypotension. In these scenarios, we have to stop chelation therapy. This is a flow chart that is actually given at internally as well. Okay, this is very important for exam. If for exam going students, we this is very important for writing the answers as well. This also helps us in identifying what to do for a patient. Okay, as part of ini, so this is simple. So we start with the initially iron ingested patient comes to an ED. See if the patient is asymptomatic or not. If the patient is asymptomatic, we get the history of ingestion and then see how much of an ingested. If it's less than 20 mg per kg, and if the patient is asymptomatic for around 6 to 8 hours post ingestion, we can actually discharge the patient. If the patient is around 20 to 60 mg per kg of ingestion of elemental iron, we get an abdominal X-ray done and send the lab value for bubble irrigation. Okay, more than 60 mg per kg patient means definitely we go into a abdominal X-ray. We take an ABG to see if any metabolic acidosis, lactate elevation, go for lavage. If the patient presents with the GI symptoms, okay, GI symptoms patients also we go for an abdominal X-ray, then we take an ABG and a lavage. Okay, after post 4 hours of an ingestion, we get the iron serum iron levels. Okay, if it's less than 500 micrograms, or if it's not available, or the patient is asymptomatic, or the ABG shows normal acid-base status, and the patient is asymptomatic for 6 to 8 hours, we discharge the patient. Okay, if the iron is more than 500 micrograms per deciliter, or a patient is showing a iron metabolic acidosis, severe lactic acidosis, okay, we go into chelation therapy. Or the patient is having systemic features, okay, can be a severe acidosis, altered sensorium, any hemodynamic instability. We get the, like normally we get the ultrasound, the X-ray abdomen radiography to know if any iron pills ingestion, get the bloods done for a metabolic acidosis, lactate elevations, we send the serum iron levels, and then we go into chelation therapy. As soon as the chelation therapy started, we need to check the urine status, if to see if there is any Windrose pattern. Okay, and if the colors is reducing or not. After the urine alteration, if there is urine is actually normal, see if the patient is clinically stable or not. So this is what, like we discussed before, once we start the patient on deferoxamine, we need to know when to stop the patient. That is when either the patient is clinically stable, okay, then we stop the patient on the deferoxamine. Or else if the Windrose pattern reduces and the patient becomes stable, we also reduces. Or else the patient is showing side effects like hypotension. If in these patients, then we stop chelation therapy. This is basically it's about IV chelation. There are actually oral chelations as well. This is actually, can we see the flow chart for this patient? I'm sorry why this is not there. Okay, so we are discussing about the oral chelation as well. The oral chelation is basically deferriperon and deferserox. This is we needed for exam purpose only. The IV chelation is deferoxamine and the oral chelation is deferriperon and deferserox. Okay, HD is not at all indicated in an iron. Okay, how do you dispose this patient? This is very important. Safe discharge for less than, like we discussed, less than 20 asymptomatic patient for around 6 to 8 hours post-injection. Patient is normal. Discharge. Patient is less than 500 micrograms per deciliter of iron injection and becomes stable in 4 to 6 hours. Also discharge the patient. If the patient shows GI symptoms more than 500 microgram per deciliter of iron, or the patient having systemic features, start the patient chelation and ICU admission for this patient. Okay. So that's it for our iron toxicity. We'll just go in just about a key takeaway from both toxicities. Okay, for the first one is the anticholinergics. What we should remember is especially for the PGs who are going for exam going. Okay, first one is the toxic drone. We discussed blind as a bat, mad as a hater, red as beet, hot as a hair, dry as a bone, and stuck as a pipe. Okay, mandatory ECG check before giving an antidote. Look for any, we discuss about any TCA injection is there, sodium channel blockade, wide complex tachycardia, QT prolongation, QRS prolongation. These things have been noted. And the next thing is about antidote, that is physostigmine. Where is it indicated? Where is it contraindicated? Indication is basically with the patient with central symptoms. Okay, contraindication is when suspecting TCA, sodium channel blockade, wide QRS, asthma patient, going into bradycardia or AV block, or patients with seizures. Okay, and the next one is iron. Here, what is important is the normal. How do you calculate with the elemental iron how much toxicity for the patient? We need to know total ingested into elemental iron divided by weight. We need to know that all the phases: GI phase, latent phase, then we go into systemic phase, hepatic phase, and obstructive phase. That is important. Where activated charcoal is contraindicated, whole bowel irrigation with PEG, and chelation therapy with deferoxamine. Okay, these are the important things that we need to know in an iron toxicity. These are the key takeaways. Okay, and the next thing is, how about we try going through the questions again, if to know that if you're actually right about this or not. So this is the first question that we did. What specific clinical finding corresponds to the classic toxicodrome? Blind as a bat, which is loss of accommodation, mydriasis, toxic optic neuritis, bilateral retinal detachment. Is my slide visible? Okay.
No.
Okay. So this is the first question that actually we looked into in the beginning of the class. So this is basically the one that we checked first. What specific clinical finding corresponds to the classic toxicodrome, pneumonic as blind as a bat? Which is it? Loss of accommodation and mydriasis, toxic optic neuritis, bilateral retinal detachment, central cortical blindness. Which is it? Yes, it is actually a loss of accommodation and mydriasis for this patient. Okay, because of anti-muscarinic agents inhibiting the acetylcholine postganglionic receptors, causing loss of accommodation because of paralysis of ciliary muscles and sphincter muscles. Okay, the next question is, an adult patient presents with an intentional diphenhydramine overdose with an intentional diphenhydramine overdose and an altered sensorium. What specific ECG abnormalities dictates the continuous cardiac monitoring? Is it the PR prolongation, QRS widening and QT prolongation, ST elevation and T inversions, or a peak T waves? It's actually the QRS widening and QT prolongation. Patient exhibiting a severe central delirium, picking at imaginary objects because after consumption of Jameson weed, and specific antidote, what is it? IV naloxone, flumazenil, physostigmine, or a sodium bicarb? It's an IV physostigmine. Administration of physostigmine is being considered as an agitator for patient. What is the absolute contraindication? Sinus tachy more than 140, wide QRS with a history of seizure, severe painful dry mucous membrane, sustained hypothermia more than 39 degrees, wide QRS complex with a history of seizures. A toddler accidental ingestion with a handful of maternal prenatal vitamins with and ferrous sulfate. What is the severe toxicity dose? Less than 20, 20 to 40, 40 to 60, or more than 60? More than 60 mg per kg is actually the dose of severe toxicity. In acute iron severe toxicity, the patient rapidly develops the profound anion gap metabolic acidosis with elevated lactates. What is the primary cellular mechanism for metabolic derangement? Disruption of mitochondrial electron chain, inhibition of renal carbonic anhydrase, direct necrosis of pancreatic beta cells, or uncoupling of oxidate phosphorylation by salicylate. The answer is disruption of mitochondrial electron transport chain. Clinical challenge 7. Patient with intentional iron overdose stops vomiting for 10 hours post-ingestion. Which phase is it and why is it dangerous? We discussed recently, so it's the latent phase. The GI symptoms resolved, the toxicity resolved, but it's actually progressing into a systemic phase. Okay. So which is the imaging modality of choice to identify if there is ingestion of iron pills? NCCT, a USG, X-ray, or an MRI? It's the X-ray abdomen. Okay, we get radiopaque evidence in the X-ray abdomen. In case of massive iron ingestion, where decontamination is strictly indicated, numerous intact pills are visualized on imaging. What is the method of GI decontamination? Activated charcoal, hypercac syrup, gastric lavage, or a whole bowel irrigation? It's the whole bowel irrigation with PEG. Okay. The last question, which is the color change indicated for successful form in rose, color colored, or bright blue green? It's the wind rose color, right? Okay. Yes, so that's the end of our discussion. So this is the end of our discussion. If you have any questions or queries, or I think in between our slides got cancelled in between. So if anything was there, if you could let me know, I can actually cover that as well. I think we could, there was one slide where I guess we could not cover this algorithm. So this is like how we started with an iron toxicity. Okay. After initial assessment and trials. This is an important for our clinical assessment and also for our patients who are giving our exams. Okay, so we start with an initial assessment. If the patient is asymptomatic and there is a history of an ingestion, if the elemental iron is less than 20 mg per kg, asymptomatic at 6 to 8 hours post ingestion, we can discharge the patient. If there is, it's around 20 to 60 mg per kg, we obtain the abdominal radiograph and also the need for any lavage we need to know, whole bowel irrigation we need to know, and also we get the X-ray abdomen and ABC. Okay, more than 60 mg per kg, or if the patient is showing any GI symptoms, we get the abdominal radiograph and the acid-base status. Okay, and then we decide about lavage and a whole bowel irrigation. After 4 hours post ingestion, we need to know, we get the iron dosage. Okay, if it's less than 500 micrograms per deciliter, patient is asymptomatic, ABG status normal, acid base status, and the patient is asymptomatic for 6 to 8 hours, then we plan on discharging the patient. If there is more than 500 micrograms per deciliter of serum iron 4 hours post ingestion, then or there is any severe metabolic acidosis, any systemic features, we go into chelation therapy. Systemic toxicity features, we get the X-ray abdomen, look for any metabolic acidosis, whole bowel irrigation, send for serum iron, and then we go into chelation with desferoxamine. So once the chelation will start, we look into the urine to see if there is a change in wine rose color pattern, and we stop the chelation once the patient shows any clinical improvement, and also if the wine rose pattern reduces. In these two scenarios, or if the patient is showing any side effects like hypotension, then we stop chelation therapy. Okay. Any questions? All right. Thank you so much. If any queries or any questions is there, kindly put it up in the group or a private message will be fine. All right. Thank you.
Thank you, Vishal. Thank you so much. It was a lovely lecture, and also the questions in the beginning and their explanation towards end was very beautiful. I liked it so much. And thank you for all the other participants who have actively responded in the group, Dr. Arya, Dr. Anjana, Dr. Pooja. Thank you so much. EM-PACT will be back with yet another session, and we'll have another speaker rounding up for another lecture in coming days. And thank you, everyone.